Good evening, everyone, and Happy New Year to all of you. This being the first academic activity of the year 2021, I wish to take this opportunity on behalf of the Society of Pediatric Urology to welcome you all to this series of masterclasses that we intend to put on throughout the year. The first in this series of lectures is on hypospadias, and today we'll be talking about all aspects of distal hypospadias. We have planned this in such a way that we have 10 chosen students along with 2 faculty members who would be answering their questions. So most of the questions have been put up by the students with some inputs from us as well. So that is how we intend to take it along. And the next series might be on proximal hypospadias, then complications, so on and so forth. So, Dr. Vikesh, would you like to welcome both the faculty and then I can ask the students?
Yeah, I think it's a very small forum, and I formally welcome both of you, sir, here, and hope we have a good discussion. We can move ahead with the meeting.
Right. So, Chaman, can you stop screen share, please?
He has left, I guess.
Okay.
Yeah.
All right. So while I'm putting up the slideshow, can I request all the students to briefly, quickly introduce themselves? So we'll start with Abhishek.
Hello, sir. Good afternoon. I am Dr. Abhishek, sir, from doing pediatric surgery from Narayana. I'm a 4th year resident.
Narayana, Bangalore, Abhishek?
Yes, sir.
Okay. Anis?
Hello, good evening. My name is Anis Ratani. I have just finished my MCH pediatric surgery from BJ Medical College, Ahmedabad. Right now, I'm practicing, and I joined as a associate professor, assistant professor at the Government Medical College, Bhavnagar.
Okay, great. Mithun?
Yeah, good evening, everyone. I'm Mithun. I'm completed my MCH training in Narayana. Presently doing my pediatric urology fellowship in Bangalore Medical College.
Great. Ashwin? Has Ashwin joined? Okay. Chitti Babu? Both the Chennai guys are missing, I guess, both of them. Those were the ones who sent in the maximum questions. Anyways, Nivedita?
Good evening, everyone. I am doing my final year MCH at CMC Vellore.
Great. Nivedita, if you can sit on a spot with a better light, we can't see your face really. Yeah, better. Thank you. Sai Gururu? Has Sai joined in?
He's not audible.
Okay.
He's not audible, I guess. Sai is not audible to us.
But has he joined in, sir? Because I have not.
Yeah, I can see him. He's
Okay.
speaking as well, but we are not able to hear him.
So is he unmuted otherwise? Sai?
He's unmute, but he's not. We are not able to hear him.
Yeah, so maybe you can work on it, Sai, in the meanwhile. And Prabhu, are you there? Prabhu?
Unmute yourself, Prabhu.
Sorry.
Yeah.
Yeah. Good evening, everyone. This is Prabhu, and I'm doing my pediatric urology in SGPGIMS, Lucknow. Thank you.
Right. Swati? Swati and Tapasya, either of you here?
Hi, good evening, everybody. Am I audible, ma'am?
Yes, you are.
Okay, so hi, I'm Tapasya Pandita. I completed my MCH from PGH Chandigarh in 2018. And currently I'm working as a consultant in Manipal Whitefield, Bangalore.
Right. All right, so we shall formally start with the discussions now. I'll request each of the students to kindly ask the questions one-to-one as your slides are being put up. And the others, if you have any questions, you can raise your hands pertaining to other topics as well, and we can take the questions accordingly. So Abhishek, you may please start.
Sir, do all hypospadias surgeries need surgery? And what is the ideal age at which we have to do the repair? And what are the pre-op investigations which are to be done? And what are the common conditions associated with hypospadias? And what we need to do or what we shouldn't do in a newborn who is referred with hypospadias?
So, Dr. Sareen, would you like to take those questions? Please unmute yourself, sir.
So
Yes.
the first question is whether all hypospadias need to have any surgery. Not only traditionally, even as of today, some of the mild hypospadias, let's say granular hypospadias with hardly any granular teratochordae, they're sent back saying that nothing much, it's just a cosmetic issue, and the patient or the subject, when he grows up, would not have any issue with micturition or conjugal issues or ejaculation. So they left, but there are a lot of studies now available which have shown that even distal hypospadias do need surgery. There are a lot of studies that have been done where they have shown that the subjects are not very happy with the look, they lack confidence, and some of them actually have problem during intercourse, etc. So I think although a universal consensus is not there, but slowly it's building up that all kinds of hypospadias need surgery.
Okay, Dr. Panjwani, would you agree?
Yeah, absolutely agree. I want to add one small point. Even if you go to the jobs like Army, Air Force, and even if you got this coronal hypospadias, they send back and they tell them go and get it corrected, then you come for a medical examination again. So absolutely agree with the Professor Sareen. All type of hypospadias, either in the childhood or in the adult age, they has to be corrected because the adult definitely they come with so many psychological problems.
Okay. And what is the ideal age of repair?
Yeah, the second question is what is the ideal age? The American Academy of Pediatrics has said that the right age is between 6 to 12 months. But I think majority of the pediatric surgeons, pediatric urologists, etc., would agree that maybe 6 months to 18 months is a good time to operate these patients. Before that, operating at 4 months, people have found better cosmetic results, etc. But there were some issues raised that if elective surgery that could wait, has to be done early, could have neurodevelopmental issues, etc. So probably 6 months is a good time to operate. There are many reasons why this age period is being selected. One, the patient anxiety is not there. They're not very conscious about their genitalia in that age. And it has also been seen that even if you wait till the preschool age, say 4 years, 5 years of age, the length of the penis really doesn't increase too much. There are studies which says that less than 1 centimeter length increase occurs. So yes, the size of the phallus, the size of the glands, and so many other local issues would decide whether how early can you take up this patient with surgery and whether the controversial hormonal treatment has to be given before surgery or not.
Fair enough, sir. Dr. Panjwani?
I prefer to do after the age of 1 year, and because the thing is by that time, I'll say the size of the penis, what you see at the age of 3-4 months, if you see at the age of 1 year, slightly bigger. One thing is that, and definitely I prefer to finish all the stage before school going, as the Dr. Sareen is saying. So but I never do at the age of 4 to 6 months. My ideal age we usually do after the 1 year.
Right, sir. And Dr. Sareen,
So
what are the...
I want you two guys also, you, Vininder, you as well as Vikesh also has got a lot of experience. So you should also share simultaneously with us.
So My preferred age for surgery also is beyond 1 year, sir. I would rarely do it before 1 year of age, depending on like what Dr. Sareen said. If a patient of 6 months comes up, but the penile length is really good for his age, only then I would take it up early. Otherwise, I try and push it around 1 year or beyond. Dr. Vikesh, do you have anything to add to that? Okay, I don't think he's around. So, Dr. Sareen, can you take up the next question, please? What are the pre-op investigations that we need? Basic investigations? Yeah.
The preoperative investigations, as far as I'm concerned, would depend on what areas we're dealing with. We're talking about distal hypospadias. Maybe I would not do many investigations, just a very basic investigations to take up this patient. So, but if I'm dealing with, say, proximal or severe hypospadias, then the situation could be different. And then I might think of doing some other investigations.
So we are talking only about distal hypospadias today, sir. So in distal
if we're talking about only the distal hypospadias, maybe I would not be doing many investigations for this other than, the routine investigations that are wanted by the anesthetist. I understand that there are some conditions which may be seen along with distal hypospadias also. But again, those concomitant urological conditions are seen more so with the proximal hypospadia. So I really not bother and would not do many investigations.
Right. Dr. Panjwani, do you prefer like ultrasound KUB in such patients?
I most of the cases I prefer to do it with ultrasound abdomen. It's not that I say there's some specific reason, but the reason is only sometime if you got some reflux or other things on so that at least we can tell the patient before surgery, because in a private practice, sometime after the surgery, if the patient has got a UTI or other problems, so at least we should be mentally prepared. So I prefer ultrasound in most of the cases, beside the routine hematological investigations.
Sure thing, sir. I'd agree with that. And that is more as a precautionary thing, I think, rather than...
It's on our side, not on the patient side.
Yes, true. And so, Dr. Sareen, if a newborn with hypospadias is seen by us for the first time, what is the advice and how should we take it forward?
Yeah, and if the patient is born in a hospital, which happens in the urban scenario, and well-to-do people, they will surely walk up to you even just after birth. So I think that's a good time to spend with the family and to strike a rapport with them and explain to them why you're trying to delay the surgery and what all you probably will do, and eventually open up with them. They would come for follow-ups and then they would eventually get operated. So there is no way you will be operating a patient when he's a newborn and diagnosed. Yeah, but again, today we are restricting ourselves only to distal hypospadias.
Yeah, so would you directly ask them to come and see you again at 6 months of age or later?
Yeah, I would call them back only at 6 months, not before that. In fact, a lot of other things also, things that we used to do in the neonatal age, like bladder access trophy, etc. For years, I did surgery, then I did, follow them up, did augments and all that. And those patients also now we ask them to come after 4 months or so, something like that. And if you would talk to them nicely, you will not lose those patients. They will come back to you. But you need to spend some time with them.
Right, sir.
Absolutely agree with Professor Sareen. And I want to add one more small point in this, especially for the rural patients. There are a lot of apprehension in their mind that this child has got ambiguous genitalia and they are HEJLA. Okay, so they come with so much this apprehension. So definitely once they come, we have to ensure them that they are absolutely male child. So this is one point. And as he's told, if you call them, we usually call them after 6 months to see the length of the penis. And I call at the age of the 1 year when I didn't operate.
Fine, sir. And I think Satish, who's one of our EC members, has added that we should specifically tell those patients not to get circumcised till the time they see us next. So that's a good point, Satish.
Especially in a more patient there.
Yeah, correct. So Abhishek, are you okay with the answers? Do you have anything more to ask, or do we move to the next slide?
Anybody among these 10, at least they should ask them.
Ma'am, one doubt is that, Dr. Anis here.
Yes, please, Anis.
Ma'am, that ideal age of repair, like, are we targeting a specific stretch penile length, or like there should be any cutoff? The stretch penile length or the width of the peri should be this much to prefer a surgery, or the age is only enough for a.
No, it's not an age. I'll come later on, and the few more slides I'll show you. It's not the age. The main concern is about the length of the penis. One thing I want to tell you, till now, there's no specific clear-cut studies from the India on this aspects. And what is the basic reason for operating after this much age of that age? One thing is that the basic points for thing is a length definitely is a very important, because in the Indian scenario, if you most of the time nowadays the hypospadias surgery is OPD surgery, so the early if you most of the time you send them after 1 day or 2 days, and the patient is from the rural background, so they don't take care properly. One thing is that, and if the penis size is small, the tracings comes out. Third thing is that there is no clear-cut parameters on about the penile size in the Indian scenario. What is the exact standard penis size at the age of 1 year? Very few studies. Whatever the studies, they are from either from the USA. Few studies are from the Egypt on the penile length and other aspects.
Sure, sir. And Dr. Vikesh is asking, what is the earliest age at which we can repair? So I think that will also depend on the parameters that you just mentioned.
Another thing depends on the capability of the surgeon, I tell you. Especially the beginners, they should not attempt for the early age, because there is a temptation in the practice. If you are sitting in a bad practice and if you get a few patients in the early part of your practice, you are tempted to do any patient what you get. But sometimes you are in a problem. Dr. Sarin want to say something.
Yeah.
Yeah, I always been telling my students, in boys, there is no norm really. I mean, although of course nominated data, one paper is available even in pediatrics, even for Indian children. But you could have a baby who's got a phallus which is very, very big for the age. And you may have a 5-year-old who's got a phallus which is too small, and both are normal really. So I think the length of the penis for boys and the size of the areola of females, they could vary to anything. So other than the size, length-wise, I would also focus on the size of the glands. Again, if you would compare the data or whatever little data that we have, the Indian babies probably do not have that kind of robust penises that we're talking about in the Caucasian population. So keeping all that in mind, you have to then decide what is best for your child, what is the best for your client.
Sure, sir. Anis, please take the next questions one by one. Dr. Anis?
Please unmute yourself, Anis.
Sorry. My question is, what are the basic principles of a hypospadias repair?
Basically, if you want, you have written is a single stage better than the stage procedure or urethral mobilization. I want to show you if you agree. I sent a few slides to the Virender.
Yes, sir.
Can you show them the basic 3-4 slides which I sent to you, which has shown the meatal opening and the urethral plate and other things? Can you show?
I have the videos that you sent, sir. I don't have the slides.
If you permit me, I can show you the few slides.
Sure.
At least they will understand quickly.
Dr. Kishore, you can share your screen and open your PPT and show.
I'm just showing you.
Sure, sir.
Anis, I want to tell you, there are the few parameters. One thing is that 99% of the patients of the distal penile hypospadias, you can operate them in a single stage Single stage, well, you can think about the single stage. This is something different. If you got a fistula formation, that become a second stage. Otherwise, most of them, they can be operated very easily in the single stage. एक मिनट यहाँ से share होगा ना. And a few basic points. Few basic points which we have to we want to show you. These are the, in my view, what we follow for here. These are the selection criteria for operating techniques. One is a location of the meatus. Another is a meatal caliber. Third one is a very important, is a glans configuration. Quality of the ventral penile skin proximal to the meatus, and quality of urethral plate. And the along last is a degree of the body. I will proceed further. If you see the meatus, if you can see these, all these patients, are you able to see on the screen?
Yes, sir.
If you see each patient from very beginning, if you see the first one, if you see this is a meatal opening. This has got a different meatal opening, and the glans configuration is different from this. This is a, and this is got a different urethral plate. So these are the criteria what we follow. Depending on these criteria, we can choose we can keep our mind from pre-operative which technique will be suitable for these patients. If I'll proceed to the third slide, third point is urethral plate. Urethral plate, the quality of urethral plate. If you see this urethral plate, you can see good soft urethral plate. This patient doesn't have any good urethral plate. It looks like a skin. This has got a good urethral plate. This is a very small urethral plate. So they are different urethral plate. This is the third factor which I keep in mind. Fourth one is a glans size. Glans size is very important. Glans size, what we measure at the widest point on the glans, is definitely the independent risk factor to prevent the complication. Okay, the glans which what we consider is a 14 millimeter is a standard size, but I tell you clearly also at the age of 1 year, hardly 30 to 40% of the Indian children, they got the width around 14. In the Indian is around 12 millimeter. Okay. So these are, and the last one is a body which is not very common in the distal hypospadias. Only we get a skin body in most of the distal hypospadias. Okay. So these are the main important factor what I prefer to keep in mind before going for any surgical procedure. Can I go back to that? What was the question?
Yes.
It was, what are the basic principles?
Basic principles.
Yeah.
What factors need to be examined before deciding on the type of repair? So that you just showed, sir.
Okay, if anybody has got any different view about these factors, we can.
So I think, sir, yes, Salim sir, please.
I think if we just talk about the distal hypospadias, CODI is not a major issue. The things which would matter to me would be mainly two. One is whether the meatus is normal or stenotic, and whether the urethral plate that you're dealing with is wide and healthy or it is narrow. So these two would be very, very vital for me to decide what procedure eventually I would pick up. Mind it, we're talking about only distal hypospadias.
Yeah,
we're talking about glandular, coronal, maybe just subcoronal. So there, these two issues will be the most important. I mean, when you ask me to talk about hypospadias, I wanted to go through all my presentation slides, whatever I may have ever presented in last 30 years on any forum. And one of the things which I realized was that because in institutions, you're always very, very busy and long list and whatnot. So many of them would eventually come with distal hypospadias and meatal stenosis. And I would ask one of my residents, Abhishek, hi, how are you?
Sir.
So we would ask our residents, to take up this patient and do a metrotomy in emergency today. Yeah. And I realized that 40% of those patients never came for any surgery after that. So
no, in every patient of distal hypospadias, you prefer to do meatotomy or those who got a meatal stenosis?
No. I'm talking about only those who the cohort which came with meatal stenosis, which would not even allow, say, a 6 French infant feeding tube going easily. So these are the patients when they come in a very thin urine stream, and I would ask this residents to do an emergency meatotomy because we can't accommodate them in next few days or weeks on our elective list. And 40% of these patients with glandular or coronal hypospadias after meatotomy never turned back. I mean, this is what I'm talking about, the slides and all, which I picked up about 15, 20 years back. I mean, now probably I would deal with these patients slightly differently.
Sure, sir. Manish, the next one.
Because you want to add something?
Point in the chat section that the quality of the patent urethra is also important. A distal hypospadias may not necessarily be a distal hypospadias just by looking at the meatus.
So yes, I want to come on that point.
Yeah.
Because the particular percentage of the distal hypospadias, they have got a bending of the glands. And if you deglove them, definitely there's a chordae. And unless until you incise that portion between the glands and the meatal opening, unless you cannot correct them, or you do the dorsiflication. These are the two methods, because few percentage of these distal hypospadias, they come with like this. Okay. And Vikesh, what is your method in the newborn or a young age? Are you do for a meatotomy? Because both of you are in a government hospital.
Like if patient is having very thin stream and a very high stream at neonatal age, then I prefer a dorsal meatotomy here.
Okay. Otherwise, in not all patients.
Not in all patients, but like if I get a 2-month baby with a very coronal or distal hypospadias at glandular meatus, then I do magpie procedure straight away at times.
So the 2 or 3 months of age. Agree.
Irrespective of the age.
The basic what message youngster we want to give you all, depending on the position of the patient. If the patient has got a thinning of the stream and the meatal opening is not visible, you have to do you're not able to put the 5 French feeding tube. Okay, and on ultrasound, if you got sometimes you got a back pressure, in those patients you should go for the meatotomy and follow them, those patients meatotomy, so that they can come for a definitive surgery.
I had a question to Professor Sareen and Dr. Panjwani.
Yeah.
What is can you tell something about the meatotomy? How it should be done in a case of hypospadias, in a distal one or in a coronal one?
See, most of the time, what I've seen in my practice, the coronal hypospadias, they doesn't require meatotomy.
Yeah, right.
Because 95% of them, they have got a good urethral opening. The meatal opening is good. This is only the distal hypospadias cases. It's got a last half centimeter or 1 centimeter from the glands. Those patients, they have got a meatal stenosis. So I prefer to do the proximal.
Okay. Sorry, Professor Sareen.
No, Vikesh, I wish to ask you, please describe that dorsal meatotomy that you're talking about, because the students should clearly know what we're talking about. Dorsal meatotomy.
Dorsal meatotomy is the part of the operation of magpie procedure, and that you keep it reserved for glandular hypospadias. While if you get like distal hypospadias, which is in the distal penile region, or a coronal hypospadias.
So what is the Vikesh, your experience after doing the only dorsal meatotomy? How many of them they again come with the meatal stenosis?
Does happen, but like most of the patients, they do well with the magpie procedure. I think that part is going to be covered in this.
See, if you are doing both the things together, that's something different. But if you are doing only meatotomy,
not only meatotomy,
we're talking about only meatotomy.
That is what I said, that if even if a small baby comes to me with severe stenosis, endoglanular hypospadias, I do a magpie procedure straight away, not the meatotomy alone.
See, our basically in Agra people, our principle about the magpie procedure is entirely different. Okay, this and as you know, all of you know, this was a very popular technique in case of the coronal and subcoronal hypospadias in 80s and 90s. But what we have seen a long-term results, after a few years, there's a regression of the meatus. And the meatal, if you see the glans shape is not good. Okay, so what we have done at Agra, we have modified the magpie procedure. If you want, I can show you the three slides. I got one single slide, I got a 5 photograph. If you want, I can show you modification. Should I show you?
Yes, please, sir.
Magpie procedure.
So while he's opening his slides, I may say, I was
Sure.
not talking about dorsal metotomy. I was talking about doing metotomy so as to slit open the meatus on the ventral side only.
Yeah, yes, I agree with you, Sarin sir.
I agree.
Okay, this is what we had done at the Agra. These were the criteria for the magpie procedure. It was less than 10% in the 2000, and but now it's a very few patient we do. This is what the Vikesh is saying. What we do the one thing.
Sir, your screen is going outside the monitor, sir.
Yes,
I think, can you reduce the
Yes,
zoom
sir.
of the screen? Zoom.
It's okay.
Is
No,
it
sir.
same? Is
No,
it
sir.
same with?
No, the upper and the lower portions are
Yeah, okay.
still not better, sir, but it's still not a good fit for the window.
Yeah, now it is better.
Yeah.
Now it is better, sir.
This is the additional point what we had done. We mobilize after doing this first step. Okay, just give the incision on the bridge between the meatal opening at the and the urethral plate, and we close this. What we do, we mobilize the glans tissue much more than what is usually done in the original magpie. You can see we mobilize the glans wings upward, then bring it in station in the 2 stage, so that the problem of the magpie, which was in the original magpie procedure, was a regression of the meatal opening has reduced. You can see this. Otherwise, the rest of the steps were the same. And the most important one thing was, which was a very thing, was the we excise the glans margin. Just incise these 2 glans margins, fashion them. And the third step was this skin should be healthy. This skin has to be very healthy. It should not be thin skin. Otherwise, we don't prefer to do this technique. What is your experience, Sarin sir?
My experience with the magpie and all is very, very limited, so I'm keeping my mouth shut.
Well, but at least you have done a few hundred cases. Your workload is very high.
I'm one of those, brutally honest person. I haven't done many magpies, so I will not claim.
What were you doing when there was no Snodgrass procedure? What was your technique for a coronal hypospadias?
Yeah, it was more or less. As I said, I have only 2 things in mind: whether the meatus is stenotic or not, and the other one is whether the urethral plate is good or not. So for something where the urethral plate is good, the groove is deep, I would do something like a gap procedure.
Okay.
And for something where the groove is not too deep and the urethral plate is not too wide, I would do Matthews procedure.
Matthews procedure. Agree. What about those patients? I want to show you one thing. It's a very clear-cut discussion. I want to know that at least the youngsters, they should know what are the options. Like this patient, if you see this patient.
Your screen is not shared.
Just sharing the screen.
No.
Yeah.
So this is the patient. This is the patient. If you see, This is a, if this is the patient, first one, if you got this patient, what will you prefer to do in this patient?
Yeah, I mean, this patient probably needs magpie, but what I'm saying is, I haven't done many magpie.
But suppose the patient is because this is only for the youngsters. Okay. Suppose this type of patient is coming to you. So what do you say to him? Because this patient is not suitable for the gap procedure. Definitely, I agree with you. It's a good for the Matthew procedure, but we will prefer to do Matthew in this patient.
Are you asking me, boss?
Yeah, I want your opinion, sir. What type of patient? Because the youngster, they should know we may be different in our techniques.
I need to see this more closely to make a comment, really.
This is an opening you can see. I can show you. This is
this is one patient where probably what Dr. Vikesh was doing, I will do that.
Okay.
Dorsal myototomy. There's a bridge of tissue on the dorsal side that needs to be taken care of.
But nothing on the ventral side. see, I tell you, the patient, patient from the South Delhi, she's coming to you. Like Veeratar, I'm asking you. Hope the youngsters are not getting bored. I agree. First, because you ask them whether we should not.
I think we are pulling it along.
Okay.
I think one good procedure for this particular condition would be a magpie, and you can add a trapezioplasty to it.
Yeah.
And added glans mobilization is something like most of us do nowadays. So that gives a better glans buttress before the meatus. So that is the takeaway, I think.
Oh, absolutely agree with you.
We can move on to the next scenario, I think.
Okay. Okay, sir. Let's proceed to it.
Virinder.
Sure. So Anis, you can take up the next question about the sutures, please.
Yes. So what is the suture technique and the sutures used for a glansplasty, urethroplasty, and skin closures? Like preferable monofilament, polyfilament?
See, I tell you, in my center, Asoka Hospital, for years, we used to do the chromic catgut, 5060 chromic catgut with on the reverse cutting needle. Okay. The reason was for this, what the Professor Asoka used to give. First, I want to tell you within a briefly about his thought, then I'll tell you. Was that it is dissolved early, there the chances of the sinus are less. Okay. But nowadays, for the last 15 years, I am using 6O Vicryl or 6O Vicryl PDS. And for the closure of the skin, I am using the chromic catgut 50 on the reverse cutting needle. This is my preference.
And would you take like continuous or interrupted sutures, sir, or would you vary it case by case?
Except in the Asoka technique, in the rest of the cases, I do most of the cases I do the interrupted. But for making the urethral tube, when you are using the Snodgrass and Asoka, I use the continuous suture. Otherwise, I do the interrupted sutures.
Okay. Professor Reed, any difference?
I've been using 6O Vicryl more or less for donkey years for almost every layer. In between, you would not get a 6O Vicryl on a round body, and using a spatulated was a problem. I didn't like using that particular needle on 6O Vicryl. Now, question about the preferred way of doing urethroplasty, granuloplasty, whether you're going to do a subcuticular suturing or full thickness suturing. Well, these are the issues which people talk about, and different people have different approach about it. I mean, I personally feel that you could do either. The only thing is when you do a urethroplasty, one of the mistakes which earlier the people who just doing urethroplasty, they tend to kind of purse string. So that should not happen. I mean, whether you're doing continuous subcuticular suturing, you must take care of that. I also understand that for glansplasty, at least, many of us, even today, and it's not even the masters like Hadidi, they're talking about putting interrupted square features and things like that. But there are others like Snodgrass who would totally abhor. I mean, they will say, okay, you even for glans plasty, just put a couple of sutures on the glans tissues and do not put any sutures on the epithelium for the gland. So these are personal, I think, issues. And I do not, I mean, I was trying to search if we have any, meta-analysis or that kind of studies available to know which is better. But I couldn't. But Snodgrass did mention that the many failed cases where they need to do a redo glanduloplasty, they have attributed to the putting the sutures, interrupted sutures onto the full thickness sutures on the glands, etc., which they say cosmetically also doesn't look good, and also is resulting into some of those failures of glanduloplasty. So I think we should know about the views of everybody. Maybe Vikesh and Veer, you should also say what you like to do. Especially when you're talking.
Yeah, I think for an urethroplasty, continuous suture is the one which is preferred by most of us. But for glandsplasty, definitely you would like to do interrupted suturing. And for skin closure, it is like personal preference. You can do either ways. Dr. Saha, if you would like to add something on this set of questions, something additional, Dr. Subhashi Saha is
No, actually, thank you for asking me. Actually, we have been just as Kishorda was telling. So we have been using always catgut for the skin, both this outside skin and the urethroplasty proper we are doing with 60 Whitefield throughout. And for the glands, we always try to use subcuticular sutures, but if the tissue is not adequate, in 2 layers, if possible. So if the glands tissue is inadequate, only then that full thickness thing is resorted to.
Thank you, sir. We can move to the next set of questions. Virender.
Yeah, Anis?
Yeah. What is the role of hormonal therapy? Like, what should be the indication, dosage? Like, how many doses to be given, the time limit, and like when to administer the hormonal therapy? Like, how many days we should keep prior to surgery, the last dosage?
Dr. Panjwani, would you take those questions?
Yeah, basically, I tell you the hormonal therapy indications are just to increase the size of the penis. They are not going to reduce the incidence of the complications. Okay, but it becomes easier for the surgeon because the penis size is increased, the gland size is increased. Okay, and if you see sometime because of the hormonal therapy, vascularity has increased, the bleeding is more. But definitely, I'm also using the hormones. Not that I'm not using hormones. I'm using in those patients where the penis is smaller for a age, gland size is small in those cases. And what we are doing, we are giving the short-acting testosterone, 25 milligram injection intramuscularly. We give the 3 injections at the weekly interval, and then give a gap of 3 weeks to 1 month. Then we operate. Okay, and sometime we used to use the testosterone injection mixing with the Nivea cream, but nowadays for last 10 years I'm not using that, and the hormonal cream is not available in Agra. So what we are giving is an injectable short-acting testosterone.
I have a comment to make on this particular point. I prefer a testosterone injection for those cases where I would like to do a 1-stage hypospadias repair for a proximal hypospadias.
Yeah, so the point is whether you need to give hormonal therapy for distal hypospadias.
Yeah, so not in distal hypospadias,
I doubt very much. So if we restrict ourselves to distal hypospadias, probably.
Okay, sir. Okay. So one more point I would like. Yeah. Okay, sir.
Even
we will not go to the proximal one, but there is one preparation called as Sustanon. Actually, this is suggested by one of our endocrinologists. It has a combination of testosterone propionate, phenylpropionate, and isocaproate and deconoate. It's a special combination available. It's a potent testosterone. And there is something like equaviron. It is not so effective.
Equaviron is a short-acting testosterone injectable.
Yes, sir. Yes, sir. That's it.
There's some query from the audience. Is it a long-acting testosterone or not?
Yeah, it is.
It's a long-acting.
As the name suggests, it's a long-acting. So
Okay.
mostly like patient, you give testosterone, they don't turn up for surgery quickly. At times, like they turn up like after 1.5 months or 2 months. So that works well there. Okay.
So what is the difference between a long-acting and short-acting? So what time period are we looking at otherwise? Like how long is the testosterone effective after you've given? Like you mentioned a scenario, if you've given the last dose of testosterone today, how long is the effect going to last? I mean, is it going to wane off over a period of time? So that's
what I have seen is a maximum 3 months. If you leave the patient, it's not turn up after 3 months, again in the same size, and sometimes what you see in the hair growth in the pubic area, they also gone after 3 months. So in my view, it's not more than 3 months.
Anyways, in distal hypospadias, there is not much role of testosterone, as Professor Sareen said.
Other than if the glans width is too small and if you need that.
Sometimes when the glans is very small, definitely it increases the size.
Sure. Other pre-op preparations are they needed? So pre-op enema and suprapubic cystostomy. Yeah.
Basically, I don't give the enema in most of the patients unless until they are constipated, because I tell them just came after evacuation, after defecation they came.
Fine, sir. Okay. And I think SPC also is more a topic that we'll discuss in proximal hypospadias.
We never do the SPC in any type of patient nowadays.
Yeah.
Now in distal, not in a proximal.
Agreed, sir. Okay. Mithun, are there any questions that you would like to discuss for glandular hypospadias, and what techniques do we use in that?
Yes, ma'am. Ma'am, if the meatus is adequate, do we need to operate a glandular hypospadias? And the standard procedure is MACPI, but what are the critical steps in those procedure which we need to do and avoid meatal stenosis in the end?
Yeah, I think Dr. Sareen had already answered the first question, but do you wish to take that again, sir? Like you said that all hypospadias do need to be operated.
Yeah, but I mean, this is what is kind of now emerging. I mean, we don't still have too many papers to say that. And you know, the things that people used to talk about is when cosmetic, psychosexual, this, that. And if you actually ever spent time abroad, I mean, it was pretty shocking for me when I first went to Sydney, and I was in the swimming pool and walked into the locker room, and everybody was naked. The grandfather was naked, father was naked, the son was naked. I mean, that's something which we probably not see in India, but everybody is looking at everybody. So those are the situations where people talk about very freely about even school children having sex and all that. I mean, let's not judge them. I mean, that's the way they live. It's okay. So, so there are a lot of papers, if you want to read, which have discussed everything from psychosexual and other issues and whatnot. Well, sure, these patients who have even glandular hypospadias have issues about their body image, and they may not be as sexually active in their adolescence and later and whatnot. These kind of papers are available. But one interesting paper which is written, which I was reading 2 days back, was that when they interviewed a lot of female partners, they never bothered about the position of the meatus as such. So I thought, I mean, the basic, this thing is that, sure, if a patient glandular hypospadias, nothing much is done about this patient. If the urethral meatus is all right, the stream is good, and stream is not falling at the feet and all that, maybe it is okay to just live like that all your life. Nothing will go wrong really. But if you really go into the objective criteria in the new papers that are coming up, they would suggest that every patient should ideally have a hypospadias repair done. I used to think earlier that, all Caucasians, everybody likes to get circumcised and all that. But there are a lot of papers which are published from those countries which say that no, they would rather have a preputioplasty also done along with some meatal procedures for this glandular hypospadias. I don't know how much more to say than because most of these procedures are pretty standard. So MACPI or a gap procedure, I mean, these are the procedures probably that need to be done for such patients.
So, Dr. Panjwani, would there be a situation like a glandular hypospadias you examine in childhood, but you wouldn't offer a surgery at that point of time, but ask them to sort of review post-adolescence and then take a call so that the patient himself can also give some input if he wants, for the cosmetic purpose, obviously, because Mithun was asking about glandular hypospadias with an adequate meatus.
Yeah, but the only thing is, I tell you, it's the mothers which are worried.
Yeah.
It's not more the surgeon, but it's a mother, especially from the urban areas. They are worried about their children's.
May I add here? If we talk about the entire family, it's the grandmothers who are worried.
Yeah, I can see the Indian
grandmother. The daddies are really worried about the size and everything about the penis.
That is in the villager background, but in the urban background, it's a mother who is worried and they want it has to be corrected. One thing is this. Another thing, in the glandular hypospadias, they are worried about the preputioplasty. They want that, in their view, that every penis should have a prepuce, especially in the Indian Hindus communities. Unless until you tell them the circumcision is better than having the prepuce. So in these patients, most of the time they won't get it done. One thing is that. Another thing is sometimes there's a spraying of the urine when there is a mega meatus. If the meatal opening is wide, in those patients, they don't have the straight streams. Okay. So as you shown the slide, mega meatus, these type of patients, although they are visible most of the time after the circumcision, especially in the Momnan patients, they are not visible. And in these type of patients, we have to operate these patients.
So what exactly do you call a mega meatus, sir?
Mega meatus, when the size is bigger, it's written roughly around more than 1 centimeter. Okay, it's a wide meatus, 8 millimeter. It's a wide meatus, and definitely they become receded at the coronal level. Although the dorsal wall is well formed of the urethra, but the ventral wall is missing. And another thing is shape is different from the normal meatus. It's a fish mouth shape. Okay. Yes, you want to say, Sareen, something?
Yeah, Veer, I wish to add something. I mean, there was some study in Europe, especially there's a Dutch study where they would have insisted that for the distal hypospadias or mild hypospadias, we should not allow the surgery to be done at birth or later, but let these boys grow up and then decide whether they want to have a surgery or not. I know there is only one paper which kind of pressurizes or emphasizes this particular, but this really didn't catch the fancy of the rest of the European countries and whatnot. So, but there are some papers which says that postpone these surgeries till puberty and all that, and let the parent, let the the boy decide for himself. And when we talk about mega meatus, I think one thing that we must emphasize is that the ventral gland is hardly there.
Yeah.
So most of the ventral glands has been actually replaced by the meatus itself. We will talk about the paper that you sent me, Veer. So there, this ratio would be really going, haywire. Somebody asked a question that
there are a few good questions there.
Yeah, which patient we should not do MACPI?
Yeah. Can I say something for that?
Yeah, please do.
When there is a proximal skin, which is proximal to the meatal opening, is very thin.
Not
out.
good. Yeah.
Not good. It's a thin out, or there is a scarring, or So those patients are not good for the MACPI procedures.
There's another question: is magnifying loop always necessary? How many of us?
That depend on your age. One thing is special. People like me, I should use, but the people like you or Virender, they can do up to 6050 with the naked eyes. There's no need. It's not in always in all patients, but definitely if the age is less than 1 year, you can have a better cosmesis. You can take a subcuticular stitch in a better way.
But I use a loop, sir. So I have a design for vision. I have a 3.5x that I use actually.
Can you, Virender, can you tell us, all youngsters, what loop they should prefer? Which company? It's not good to quote a company, but it's always related with the type of loop.
Yes, sure. So the Indian scenario, we have different loops which are available, sir. It actually depends on, in the beginning phase, I mean, my personal advice would be that you should start with a good loop only. The thing is that when we are residents, I mean, I did the same, that you try and buy a cheaper version, but you never get used to it. So there is a lot of, head spinning and you have a heavy head when you use those loops. So they are never comfortable to use if you don't use good ones. But even now, you have a lot of companies like Healer, Heinz, Zeiss, all of them. Healer is a cheaper version. I think it gives you a good focus.
The spectacle one or a headband one? Spectacle one or a headband one?
I personally started with a headband, obviously because they are cheaper as compared to the spectacle ones. But I've used both versions and I prefer the spectacle version better. It's more comfortable to use, although it's more a matter of getting used to it.
So the takeaway is like hypospadias surgeons, especially the beginners, they should always use the magnifying loop.
So I guess because when you start early, you can continue using it for a very long period. It becomes difficult to get
I'm a devil's advocate most of the times wherever I am. I've never used a loop ever in my life, and I'm probably double the age of Vikesh, so still managing.
No, you aren't.
It's not like that. Sorry, don't make us too old.
Okay, so I haven't ever used, but those who use, very good. And
I use 2.5.
When you start using loops, then you prefer to use loops for neonatal pyeloplasty, neonatal anastomosis. So I think it is always a good.
I agree. So there's a couple of comments that are coming. One of the things which I wanted to add to MACPI. One of the comments, one of the questions was MACPI. We talked about some of the contraindications to MACPI. One other thing could be when the ventral lip intraoperatively you plan to go to do a MACPI, but you see the ventral lip that those tissues there are not too elastic. I mean, then you probably cannot do a MACPI. And loops, yeah, everybody is talking about loops. Good investment to make early in career. Sure, please give me. My birthday has just gone. Thank you so much.
So. Should we finish this mega meatus? I'll take one more minute.
Yes.
This is cases which are very difficult to treat in comparison to the other distal hypospadias. And in these type of patient, the reason is glandular tissue is deficient. And another thing is the meatal opening in a different way. So we have to make the urethra, we have to give an incision vertically on the proximal side. You can see on the photograph. They are different from the gap procedure. If you see, we have to incise on both the side, make a raw area, and you have to give the incision on the proximal side, make it a triangular so that we can elongate the urethra. So this procedure is a bit different from the gap procedure. Gap procedure is comparatively easier procedure than this procedure is called pyramid procedure, and then you close the glans over it. So for the youngster, I'll say we should take an extra precaution in these type of the patients. Don't take it lightly, please.
Sure. Okay. And you had a video for Matthew procedure, so can I run that quickly so that you can just?
Sure. Yeah. This was a video which I got from the Ashley D. Cruz. This is not my video. Okay. And you can see he has shown the two procedures in this. The most important point in the Matthew procedure is raising the proximal flap of the skin. One thing, another is closure of the glans wings. These are the two important points which we should have idea before proceeding. If you see this raising this proximal flap of the skin, the ratio should be 2:1. It should not be very long. In the older time, there was another procedure like a Mustardi procedure, when we used to take a long flap from there and we make a tube and we used to bring it. But the vascularity was the problem. So in the Matthew procedure is very suitable, very good cases in the distal most hypospadias. The only problem for which he gets the criticism is a open wide meatal opening. For just to prevent that, what we do, we give a triangular incision in the midline and we close them, approximate them so that the meatal opening should be circular. These are the 2 points which we should keep in our mind. Third thing comes in this type of patient when the glans size is very small. In those patients, Matthew procedure is not always successful and the glans closing is very tight. As you are seeing, this is a glanduloplasty, what we are doing.
Would you like to transpose a dartus flap?
Yeah, it's coming. It's come. Another step is after that is a dartus. So you can see this is a one opening which is giving here, and we most of the time we close this with the adjacent tissue. This is at raising the dartos fascia. You can see raising the dartos fascia, and for the important step in raising the dartos fascia is whether you bring it from the lateral side, whether you bring it make a buttonhole. There should be no torsion once you stitch this on this. So we should be proper mobilization of the dartos fascia up to the base of the penis. Well, that means you should go at least 3 to 4 centimeter on the proximal side so that there should be no torsion.
And what are the exclusion criteria for a Matthews procedure? Like which patient you shouldn't do a Matthews?
One thing already told you, the proximal skin should be healthy, thick. One thing, it can be raised easily. There should be no fibrosis. Another thing is glans size should be good. These are the two main important things.
Meatal stenosis?
Meatal stenosis should not be there.
Yeah.
And if you have done the meatotomy, then you should be very careful in those cases. Because in this, the vascularity is from both the opening, from both the lateral side of the meatal opening. Yeah.
Right, sir.
Sarin, sir.
Yeah, it's very important that we don't choose a patient whom we name as hypoplastic urethra and all that. So that's very, very important, very clear. Also, you should try to pick up a thick skin flap really, which you are going to transpose over. And as Dr. Had already said about the Mavis V cut there, he's already mentioned that. I also used to always believe that this Matthews procedure is for the primary surgery where metotomy is done or any other thing has been done, you should not use. But then suddenly Rakesh Joshi from Ahmedabad said that no, he uses it primarily for his secondary cases. And that is the time when I sat down to read all literature that is available for Matthews. And even the Hadidi book, which I have shared with all the students, I mean, clearly mentions that at least 1/4 of his patients were the ones for secondary surgery, where all kind of other surgeries have been done. The only kind of contraindication for a secondary surgery is that there's not much scarring in that area where you have to. And about this modification of putting a second layer, it doesn't need to be always a dorsal dartos to be brought. You could pick up dartos from lateral, ventral, wherever locally available, and put it up there. Ideally, yeah, it could be a difficult proposition to do, especially this second layer if the glans is small. So the skin probably it will still take, but if you would need to put this second buttressing layer and the glans is small, then it could be a problem. My problem with Matthews, I don't know how many share it. I read a lot about it, but didn't find much to support my experience. Is two small little fistulae that used to happen on both sides from where I start my repair. I don't know why and how, but over the years it's improved. But I used to have a lot of fistulae initially when I started doing Matthews. Two small little pinpoint holes on both sides where the corner stitch. So I started burying that corner with another extra stitch there. And then I read more that, you can take stitches from the mesentery also, superficial stitches on both sides and fix it onto the, the bed in the glans. Which probably improves. And then comes the similar procedure, which is known as Barkat, or what is the name? I'm forgetting. Barkat procedure. Barkat procedure is something very similar to Matthews. Basically, there you don't only raise the proximal, you also raise the urethra from the glans and make a tube out of it, and then take off some of the glans tissue in the glans bed and then bury this urethra right deep inside the glans repair that you're going to do over it. So I believe Barkat procedure is quite popular with some of the adult urologists who do it. So it's something similar to Matthews, but a little more intricate and a little more.
Sure, so we'll move on to the next slide. We're already 1 hour into our discussion. So Ashwin, what are your questions about coronal and subcoronal hypospadias? Dr. Ashwin, are you there? Or otherwise, Dr. Panjwani, what is your take on coronal and subcoronal hypospadias? When do you do Snodgrass or TIP procedure?
See, I tell you, only the coronal hypospadias already we are talking about the magpie, the conditions, about the Snodgrass procedure and the Matthew procedure. How does I decide among these Snodgrass, Snodgraft and the Matthew? I do only these 3 procedures in the distal hypospadias. Okay. So my preference and for the tip procedure is when the urethral plate is wide, means more than 8 millimeter. I don't do in a very small urethral plates which are less than 8 millimeter. One thing is this, and I do in those cases when the urethral plate is small, I prefer for a Snodgraft or a Matthew procedure. This is the way with I proceed, and I give the additional barrier with the giving the Dartos flap in the fresh cases. But in those cases when already they are the redo cases and we are using these techniques, in those cases I do the tunica vaginalis flap. Okay.
Sure, sir. So would you wish to run through the steps of TIP in the video?
I'll say this is a video, and in most of the cases, what the people do mistakes in cases of the tip procedure, they take a part of the skin beside the urethra, just so that they can ensure a proper closing of the urethra. So I don't do those cases. In those cases I do, but in these cases you can see in every case of the distal hypospadias, we do the proper degloving of the penis so that we can get rid of the skin body, because few these have got a bending of the penis which corrected itself with the degloving. Then you see the size of the urethra. The salient features, there are 2 salient features. One is raising the glans wings. We go up to the point D, as you will see in the distal slides. And in between, when with the incision in the urethra, this urethra incision should be deep enough, because itself, Snodgrass, he used to give the shallow incision in the initial phase of his studies for a year. Then he realized there was a problem with the stenosis, and later on he himself modified this. He gave the proper incision in the midline so that you can see the glycerin tunica and you mobilize the flesh laterally more properly so that you can have a wide groove where you can put the catheter properly and close the lateral margin. So that these are the important steps. These are the important steps.
Your voice is echoing.
Procedure in easy time. Okay. Another thing, we should not proceed too much about the distal aspect.
Your voice is echoing, sir.
Is it okay now?
Okay, meanwhile,
So everyone's voice is echoing.
I think other people need to mute themselves. Those who are not speaking need to mute.
So the salient features is 3 in the sonograph. One is urethral plate size. Although sonograph himself don't agree on this, he is doing a very small 4 millimeter, 5 millimeter wide urethra plate, the same procedure. Another is bringing the urethra not up to the tip of the penis. It should be little bit lesser on the point up to the point B. Third thing is it should have a good coverage from the additional layers. These are the 3.
There is one question from one of the participant, Dr.
Yeah.
Mithun. If you learn quite a few procedure for hypospadias, then what would be the best procedures? Like minimum procedures which you should learn for hypospadias.
There are the only 2 things which
Yes,
you can finish. One is a Snodgrass procedure, as they say. Another is a breakup procedure in the 2 stages. Distal hypospadias, they do all the Western world. They are doing. There was a time they used to do with the Snodgrass and either 2 stages. But in our India, none of us, we are following these 2. We have to learn at least 5 to 6 techniques. At least not less than 5, 6 techniques. Otherwise, you will not come over the complicated cases. What is your opinion, Yogesh?
I think every hypospadias has to be individualized. So although 250 odd techniques have been mentioned in the literature, one must know at least 5 or 6. I mean, this is my opinion. A couple of things I need to ask and clear my own doubts, even though I'm being delegated as faculty and all that. One is that when we used to anyway do 2-stage procedure and all that, we never talked about urethra. We were making urethra out of the skin only. So suddenly, why this dislike for the adjoining skin and talk about only urethra? That's something which I have not been able to understand. Especially when we're talking about doing only distal hypospadias, we are not going right up to the penoscrotal where we are worried that some hair may come and all that stuff. Number 1. Number 2 is snot graft. I haven't done many snot graft, but I heard people doing it. And I've seen some of the results where that snot graft that has been put in probably was larger in size or whatever. I've seen that skin prolapsing out of the meatus. So I would seek some advice from Dr. Kishore, please, to clear these 2 doubts.
Yeah, one thing is that if you see the quality of the urethral plate and the skin, if you see there are a few studies histopathologically, they are different. And because of that reason, all the flap procedures, they came in form because the inner surface of the prepuce, they got the same type of quality as the urethral plate. Okay, the same quality was with the buccal mucosa. Those type of, the texture is comparatively softer and the chances of stricture formation are less in the skin. If you take a part of the skin along with the urethral plate and you bring them, so in those cases, chances of strictures are more in comparison to only if you take the soft, supple skin, the soft, supple urethral plate. Okay.
I agree with those papers. I have also read them, but I can tell you, I mean, I hope I should have come with some slides.
Okay.
But there are penises where the skin around the urethra is pretty supple. Actually, it's just the minimal change in the color that only will differentiate. There could be other patients where there is a real urethral lip, which demarcates the urethra from the skin. Yeah. But there could be other cases where that transition is quite gradual. You can hardly make out. So personally, I think in those cases where that lip is not there and that the urethra is almost merging into the very glossy kind of skin along, I would not mind taking a part of the skin along. I mean, that's my personal kind of.
See, I take only skin in cases of the adult hypospadias because I do the adult hypospadias also. If you see the adult hypospadias patients before surgery also, you will see hardly different urethral plate than the skin. It merges with the skin, and even the color has changed in those cases. And
I would like to add point here, sir.
yeah,
I mean, it's very difficult to settle this debate, but there are many surgeons. They say that they do a sonograph for a 6-7 mucosa lined urethra, but definitely everyone has done what Professor Sareen is talking about. But as a teaching mode, we should not be talking about that. If we are talking to the youngsters, then the best case for snodgrass would be a case where there is a good wide mucosa lined plate. That should always be a preference. But okay, with experience, you start doing these things, you find good results. That should be okay. I think we can move on to the next.
No. My question about snot graft.
yeah, now should I have given a very small, precise answer? I use the synod graft procedure only in the redo cases, except only in the redo cases when there's a post primary surgery, there is a stricture formation. In those cases, I do use the synod graft procedure. Otherwise, it's not my preferred method for. I
It should
use
not be a primary procedure.
yeah.
Not graft should not be a primary procedure. Virinder, you agree with this?
I agree with that, sir. I'm sorry, I'm just trying to troubleshoot the system because Mira.
Okay.
Yeah, sorry.
Can we move on to the next set of questions?
Sure, sir.
Yeah.
I think it was about distal hypospadias. I'll share the slides. I mean, the system just hung up.
Yeah.
Meanwhile, I'll ask one question. On follow up, what is your metal calibration policy, Professor Panjwani and Professor Sareen?
See, in my setup, I don't call them regular for metal calibration unless until they got a problems. I don't do in cases of any type of procedure. I don't do the regular calibration. Neither I teach them, neither I give them any device unless until they got a problem. Then they come to me.
Professor Sareen?
Yes, I agree with you. There's no consensus about it. The majority of us, we believe that unless the patient is symptomatic and his stream is not good or he's getting obstructive symptoms, strangulation, etc., they should not be, subjected to routine kind of calibration. But I also know that very prominent urologists and those so-called those who call themselves hypospadiologists, I know also say that they do first calibration in 1 month, and if they feel narrow, they will go on doing calibration for next 6 months, monthly basis, etc., etc. But what I wish to highlight here is that calibration is not a simple thing. It used to happen in my OPD. It would probably still happening many places, to hold the child down and try to do, push the.
Virender, Yogesh, what is my experience? If a patient require repeated calibration, it's not going to correct. It
Yes.
require a redo surgery. If require 2-3 calibration, that's good enough. If you require more than that, we should think about the redo surgeries.
Yeah, there is no doubt about that. Now, what I'm trying to
I'm
trying to highlight is that I'm talking about public hospitals where a lot of patients are coming and all that. I mean, not that there's any excuse for it, but I've seen patients being forced down to the bed, and residents are trying to push in 5, 6, 7 infant feeding tubes, etc. I think that's very traumatic. It causes false passages. It causes more trauma. So if you are really, really thinking of this patient having the need of calibration, please do a couple of procedures. I mean, maybe if you have a urodynamics with you, do a uroflowmetry, you do a urodynamics. If there is a worsening, hydronephrosis or PVRV is significant, etc., then these are the patients probably who need something more than just calibration. Don't hold them down and just forcibly. It doesn't work. I mean,
right, Dr. Sarin, we agree with that. I think we'll come to that part, Euroflow, and follow up later. Dr. Panjwani, this was your video on snot graft.
This is a beautiful video which has incorporated 4 techniques together. Okay. So this was a case of mid-penile hypospadias with a skin cording. Okay. So in this patient, what was the first step was just to deglove the penis and by protecting the urethral plate and check the artificial erection for the cording. If there was a little bit cording, which is corrected by excising the this spongiosal tissue, then give the raising the glans wings. You can see these are the raising the glans wings, and after raising, you can see the again you check the erection. If there's a bending, then we go for the midline dorsiflication, single dorsiflication, the midline. You can see, and after dorsiflication, you again check. This is the dorsiflication. Then after that, you check the width of the urethral plate. It was a small. You can see. Then you plan for the snot graft. You can see the depth of the incision. It should be deep enough so that you can have widening of the urethral plate. See the method how you raise the thin prepucial graft. This is a thin prepucial graft. You're taking from the inner part of the prepuce and incorporating this thin graft into the gap. And the important step is the quilting of the graft so that there should be no prolapse of the mucosa or skin from the hiatal opening. And after that, you close the urethral plate to rise it. Then after that, the important step is if you should not have the eversion of this skin margin. You have to close. If you have got an additional, you can take an additional layer of the sutures. You should take, otherwise should not take. Then how do you raise the tunica vaginalis flap? You can see you raise the tunica vaginalis flap from the left testis. There are 2 precautions which we should take raising this to protect the vessels. Another thing is in the few of these cases they got an ascended testis after this. So we should take a measure for ascending testis also. You can see I'm fixing the testes with the bottom of the scrotum so that we can get rid of ascending of the testes. Another important step is to fix the base of the penis with the ligament, suspensory ligament, so that there should be no burring. On the ventral side, you can fix up with the penile tissue with the scrotal. It prevents the burring of the penis. Okay. Then
very important point.
Another thing is after that you check there was a shortening of the skin on the ventral side. So we are taking the double island flap from the dartos. So this technique, this case has covered the 4 techniques: snot graft, dorsiflication, tunica vaginalis flap, double island flap. This step is very important just to prevent the torsion. You can see. Just give the incision on the scrotum. We are just merging with the penile skin. So the middle part of the ventral side of the penis will be covered by the double island flap.
Tunique or without tunique, sir?
This is without tunique.
What is your preference with tunique?
Most of the time I use, in the case of the proximal hypospadias, when I do the cording erection, I use the tunique. But in the case of distal hypospadias, most of the time I don't use the tunique except for the artificial erection. You can see this is the final picture of this patient.
Yes, Professor Sarin, please.
Yeah, one issue which I wish to raise here is that tunica vaginalis is that flap is like any other random flap. It does
Yeah.
not have major blood supply. So that 1:3 formula has to work here also. So if you would take a very narrow tunica vaginalis flap and think that it's going to survive and act as a buttressing, it would not. So take it wide. So it should really, it could go even beyond your urethroplasty kind of lateral sides. It should be a wide tunica vaginalis flap sitting there. Then only you can ensure the.
Very good point made, Professor. Yeah. Now we'll move on to the next set of
Yes.
questions. Yeah, please.
Nivedita?
Nivedita.
Yes, sir.
Yeah, please.
I wanted to know when we mobilize the spongiosum, a lot of times we identify it after we cut into it. So is there any foolproof way of raising the spongiosum of the corpus cavernosa without injuring it and identifying it intraoperatively?
Can I answer all these questions? I made some slides. If you don't mind, I'll show.
Yes,
I mean,
please,
I'll
sir.
answer all these questions along. I've read those questions and we'll talk about them. And if I forget to kind of
Yes, please, sir.
take
Sure.
care of any of them, please ask me again. Yeah?
Sure, sir.
If I could share my screen.
Yes, please, sir.
Sorry.
In the meanwhile, Dr. Panjwani, can you tell the residents how to sort of identify the spongiosum before they start?
You can identify most of the cases. You can have a rough idea before doing any operative procedure, just by seeing the penile on the ventral surface of penile. If the spongiosal tissue is good, you can see the good bridges of the tissues on the both underneath the skin, and they divert laterally and near the glands. Okay, so this is the one thing before giving any incision. Like you can see on the first slide of the first photograph of the slide, you can see good bridges of the. These are the good. You can see these are the good spongiosal tissue. You can make out the idea. Okay, this is also you can see this. There's a good healthy spongiosum on this. He is making. Yeah, Dr. Sarin, you are ready. You please speak.
Yeah, so first question is that how do you see? First of all, is when you have to do the degloving, which side do you start? Start on the dorsal side, not on the ventral side. So that once you get into that plane, just
Someone need to mute their audio.
I muted, sir.
Okay. So the first thing is that when you initiate the degloving, always do it on the dorsal side. Once you get the plane right, and then go on to the ventral side. So I agree that the degree of spongiosal tissue that is available in case to case could be different. But then if you would follow this, probably you will not miss out on spongiosum. Actually, spongiosum, you have to think of it, then only you will be able to preserve it. I mean, a lot of surgeries have been shown earlier. Nobody has talked about spongiosum because it is, once you start giving importance to spongiosum, you will start looking for it and always preserve it. Okay, so this is the only classification I could get from literature about what is good, bad, or whatever of spongiosum, because we all know that the whole lot of tissues as the second layer is known, whether it is dartos, whether it's dorsal, ventral, lateral, whether it is tunica vaginalis, so forth. So there are few surgeons who would use only spongiosal tissue. And then intraoperatively, how to know whether this spongiosal tissue is good and whether it should be the only layer or whether we should have another layer. And this was also one of your questions. So here is the classification. They have divided into poorly developed spongiosum, moderately developed, and well developed. The poorly developed is thin spongiosal tissue with decreased vascularity. Once you repair it, this will be not as good as the spongiosal or the proximal urethra look like. When we talk about moderately developed, it will be average thickness, and once you repair it, it will look something very similar to the proximal urethra with the normal spongiosal tissue. And well developed is where it even looks better than the more proximal spongiosal tissue. So this is the classification that has been given by Bhatt and al. From Bikaner.
So,
And I
so we need to quickly, I mean, wind up because a few more questions are left. So, can you summarize, sir, about spongioplasty, please?
Spongioplasty is something which many people do not know. That's why I made the slide. Otherwise,
Yes, sir.
the slides, they're not
We would
issue.
like to see them.
Yeah. So basically, this picture is for poorly developed corpus spongiosum, with according to the classification. This is which is moderately, and this is the thick spongiosum, robust. So these are the patients where probably in the second and the third case, you probably don't need another layer. But in the first, you would probably be not sure and would like to put another kind of layer on it. This is another slides which say that, spongiosal tissue, how to know where it will bifurcate. So the more the caudy, more proximally it will bifurcate. So you have to deglove all the way down so as to go to the normal spongiosal tissue. And from there only you will come to know where the spongiosum are divergating. And from there only you go ahead about it. Just few seconds, Vikesh.
Yeah, no problem, sir.
Now, this is the steps that they're showing. I mean, there are a lot many different procedures which are mentioned if you really go through the literature, how to do spongioplasty. And I thought probably we should discuss that. Here, there is a longitudinal incision made on the lateral side of the spongiosum, and the spongiosum is now lifted. So you will raise the right spongial pillar, and then you will raise the left spongial pillar, and then in between the urethra is repaired, and then you will get the second layer over it. So here, of course, the suture line will be more or less overlapping each other. But if the spongiosal tissue is too much, then you can even do double breasting of the spongiosal tissue here after doing these dissections. So this is a very, very, although I believe if you really go through the literatures, it was 1995 somebody first mentioned about spongiosal tissue being used. And then in 1997, Morikuma, he kind of Frenchman, he talked about it. But this is the article which is really talked about, and everybody talks about this Y2I wrap. Basically, if you would see these pictures here, so the spongiosal tissue which is bifurcated, once you've done the urethroplasty, whatever type of urethroplasty you want to do, whether Duplay or whether this is more like Matthews, then you can get the spongiosal tissue closed in between. So the Y becomes the I here. This is another study from a Frenchman published in 2004, accepted in 2002, of course, is where he has actually made incisions not only laterally, but also in the midline, and separated two spongiosal pillars, totally, these are on the loops actually. These two pillars have been lifted on the loops, and then they have been repaired in the midline over the urethroplasty. So this is what you all have already seen. This is how good spongiosal tissue would be looking. Then you've done a urethroplasty, and then you have got both the pillars over doing the spongioplasty. This is double breasting spongioplasty where the tissue is very good. So you have put one, and then you have got the other pillar over it and double breasted. So all kind of things have been done. Now, this is one paper which I wanted to take up. I just wondered whether the authors are going to be there in this group. But in any case, now they say that they have never been able to identify spongiosum very, very well. So what they do is whatever ventral tortoise issue is there, they go into the plane just above the urethra and lift it up. I think this is not the way to do it. This is something which they probably have not understood. And I just showed this slide just to show how spongioplasty should not be done.
Sir, we absolutely agree with you, sir, that a good degloving will preserve the spongiosal tissue. Most of the times you knock down the spongiosal tissue while you do the degloving.
Yeah,
so one has to be very, very careful.
Yeah, so the last slide, I think, which I'm talking about here is the obviously, if you have a good spongiosal tissue, then probably the incidence of complications and fistula, etc., will be much less. And probably in that case, you will not need a second layer. But if you think intraoperatively that the spongiosal tissue which you close the urethra is not good, defined as that is not as good as the proximal normal spongiosal tissue, then you probably put a second layer. Next two slides, again, devil's advocate. Not many people talk about it, but yeah, some people talk about it. Now, this is funny. This is what we call as hypoplastic urethra with no spongiosal tissue over the urethra for a long distance. Yeah. What do you do for this? People talk about degloving and then they say, oh, where the original meatus, that is not the hypospadias, we will cut across, and then this coronal one or glandular one eventually will become the penoscrotal hypospadias, correct? There are few surgeons only have discussed, and I thought, because I also wrote a paper long many years back, so we will talk about it. So here it is Smay, our Egyptian fellow, he talks about hydrodissection and says, try to get the skin off this urethra and try to preserve this urethra, and then think of whatever, anyway, you will have to create a urethra, no? So if the urethra is there, devoid of the tissues over it, why destroy or, cut across the urethra and then again try to repair it? So,
sorry, here I will interrupt you.
Yeah.
Just for the sake of beginners. You think
one second. Let me show that
it's so easy to separate the skin, these type of patients, from the urethra. It's very difficult to separate the urethra.
It is not. It is not. It is not, and that's why there are not many papers about it. In any case, so this is what we had published in 2006. I stop here and stop sharing my screen here. So I totally agree with you, Dr. Panjwani. It's not very easy. You need a very meticulous dissection if you want to save this. But what do you do in such cases? You cut open, and then what do? You again repair the same urethral tissues all over again, isn't it? So, or you do two-stage procedures in such cases. So that's all I have to say about spongioplasty. And then
good collection of material, Professor Sarin.
Have I missed out on any question, Nivedita? Suture material.
Please unmute yourself, Nivedita.
Yeah.
Okay.
And suture material, we can use PDS or
PDS 6070 people have talked about. I mean, of course, Snodgrass not talking about using 90 everywhere. But I think I have even used 50. I mean, being very, very honest. So 6070 is what most of the people talk about. I've answered your fifth question. I've answered your fourth question. Yes. When do we decide not to do a spongioplasty? Obviously, if the spongiosum is not there, how would you do a spongioplasty? And if it is a very severe CODY, whereas a dysplastic fibrotic spongiosal tissue that is causing CODY, that's the tissue that needs to be excised. So obviously, you can't use the spongiosum.
Yes.
I think I've answered most of your questions.
Yes, sir.
Right.
Thank you.
So, Virinder, before we move on to the next set of questions, there are about like 15 minutes left. So we need to wrap up quickly. So I'll request the experts to be precise in their answers for next set of questions. Thank you. I think this part is covered.
Yeah. Waterproofing, Dr. Panjwani, you've already demonstrated. If Sai has more questions on that.
Yeah, basically the thing is, I tell you what is my way of operating in the cases of the distal hypospadias and the fresh cases. If I'm doing first time, in those cases, I prefer to do the dartos fascia, not the tunica vaginalis. In cases of the only proximal hypospadias, where I am not using the flap procedures. In those cases, I do the waterproofing, especially in the redo cases. In those cases, tunica vaginalis flap. And already I told you there are two problems. One thing, Dr. Sarin has corrected the flap ratio, width and the length. Another thing is how to prevent the ascending testes. These already I told you, and definitely the waterproofing is a very good method to reduce the fistula rate. That the authors have got a different way of raising the dartos fascia. You can see few people they bring it laterally, few people they bring it by making the buttonhole, and few people they do the double breasting. The main thing is It should be vascular. It should not for the sake of just for raising the dartos fascia. Another thing is you should take care of the outer penile skin, because during raising this flap, we always forget the outer skin, and that become a thin out, and later on this become a necrosed. So that thing we should take care in the dartos fascia.
And what about like stitching it well beneath the glans?
Yeah, it is well beneath the glans.
Yeah, yeah.
Should not come up to the tip. It should be take care of that.
Thank you,
So,
sir.
Prabhu, do you have any questions for glansplasty?
Ma'am, can you hear me?
Yes, we can.
Yeah. So good morning. In these two cases, if at all you wanted, you have 3 points, like in straight to the question, like granuloplasty, sir. If you consider the point A, B, and C, what will be the difference between the distance between A, B, and C in both these cases? How do we decide?
This is an interesting concept. As I said that you know, a lot of people used to have some subjective way of knowing how deep is the groove, or for that matter, even you know, two people, the width of the urethra, there was a lot of issues. So people have now come out with this ratio where AB is actually where the meatus is, and the BC is what the ventral glans is going to be. So basically, they say that if this ratio AB over BC is more than 1.2, probably then the groove is deep and the urethra is wide. And in those procedures, obviously, you can do one of those procedures that we talked about, gap and all that stuff, you know. And if the AB divided by BC is less than 1.2, then probably this is a very, very shallow way where the tip will not work, where tip will not be able to give you. So these are the patients probably you either need to do a snot graft or you need to do some alternative procedure. The tip will not work in this case. So these are glansplasty. There are, if you read the heredity which I had sent to you yesterday, there are so many different, about dozen odd ways of doing glansplasty, including the coring and this and that. And but glansplasty, there are a few things which I must emphasize here is that in my early days, I would try to get the tip of the meatus as far and then try to get a very longish kind of ventral glans below. And also that suturing would be under tension. But now a lot of people have started saying that if you could achieve as much as 4 to 5 millimeter of ventral glans in boys, I mean, I'm talking about younger boys, 5, 7, max 5 years old, then that is good enough. There is interesting papers that Satish Agarwal and you know, some other people had presented where they said that don't even close glans all the way up to the carina and bring the skin there, because if you close the glans under a lot of tension, then the problems of visualization there occurs. So glansplasty, I don't think I need to say
So,
more.
sir, as you rightly pointed out, the key message here is there should never be meatal stenosis. If glans is not good, compromise with the glans buttress, but your meatus should not be narrow.
Meatus should never be narrow. Meatus narrow means problems, fistulae. Meatus narrow means the patient will be coming back to you. Meatus narrow will be there. You will be doing redo surgery most of the time.
During surgery, it will look very good, but post-operatively, it will give away or it may result in bad stenosis. So now, can you move?
There is a paper from Ramesh Babu, which we've shared with me, which clearly states that if the same material, if you would mark these points, then the results are much better than if you start the surgery without marking these points. So probably it's good to mark these points and then start doing this.
A couple of more, if I can take 1 or 2 questions, sir. So if this is a glans dehiscence, right now what you're seeing is a virgin case. If at all is there was a glans dehiscence, will there be a change in your markings, ABC? And the last question would be, sir, how will the downsizing the tube in this, like, you know, intubating, will help at the end? Does that have a role in preventing the meatal stenosis? These are the 3 questions.
No. The second question is whether it should be stentless or stented. Are you asking that?
No, downsizing the tube at the end of the surgery, sir. You do it with 8 and downsize it to 6, something.
Well, I'm not a big fan of that. Actually, I think I've heard that and I've known that, but I'm not a very fan of that, because once you take out the number 8 and you can't, then you're struggling to put it another tube. It could be a problem. It should not happen if you have done a good size urethra, good size metas, but I would not probably get into it. Maybe others do it. I don't do it. And the first question is how to know. These anatomical landmarks can be known only on virgin case. It cannot be known on. So in that case, what will you do? In that case, you will like to measure the metas that you need to create. Okay, what is the size of the metas that you want to create? You want to create at least 8 to 10 French. Less than 8 French, you should not even do at 6 months. So then there is that point A would always be available. So you have to measure B on both sides before you start kind of doing your surgery. And those 2 sides, 2 ABs, 1 plus 1, should not be less than about a centimeter. That's how I would look at it.
And he asked about redo cases. So redo, it depends upon the availability of the glands, Prabhu.
I tell you, in the redo cases, ideally we should do in a 2 stage. One thing is lay open the glans wings properly and put a graft over there. Okay, leave it for 6 months. So it become a wide, deep groove glans. Then you can raise the again flaps and you can close it easily. It's just node graft procedures. Okay.
So we will cover this redo part in great detail next time.
One sentence here. There may be cases of redo surgery where the glans is too small left. There's hardly any tissue left.
Yeah, it happens.
And doing anything fancy, even this graft business will not help.
Nothing. In those cases, you should do the subcoronal.
Yeah, leave it at corona. I mean, don't over attempt things.
Redo is a Pandora's box. We will open it next time, sir. Let us move on to the next this thing, propusioplasty. We have already spoken much about it, but is there any particular point you would like to make, Professor?
I will tell you one thing only. I'll show you the one slide. Okay, I'll share one slide. Can you?
Yeah, Prabhu, you were asking a question. Can you just say your question?
Please.
Yeah.
Thank you. Sir, I have a couple of questions. One is, do you have any prerequisite? Like, can we do propusioplasty only in these cases?
I tell you, when the few percentage of the hypospadias patient, when the pupil size is small, although it's very more common in the case of the proximal hypospadias, around 80%, 80 to 85% cases of the distal hypospadia, they got a good pupils. So the propusioplasty is not a problem. The only problem is how to do it, how to get rid of these type of complication you can see. These are the complications which I have seen. I prefer to do the propusioplasty like this. You should not be too tight phimosis. Making a phimosis in the case of propusioplasty is like this. You can see the phimosis. On detection, there is a bleeding. Another thing is making a fistulae in the propusioplasty. So, in my principle, is should not be too tight propusioplasty. You should have at least you can see the face of the glans. Okay. So for that, you should not raise a much gland. Another problem with the propusioplasty is fistula formation, especially in cases when there is a fistula and the fistula is covering the outer skin also. So just to prevent this, you should take care the proper lifting of the glans wings, like in this the slide which you have shown. This is my basic principle.
So what percentage of children, if at all you did a circumcision after propusioplasty, after so much of effort, how
many of them I done because in the initial years, when I saw the propusioplasty, it was not very common in the 80s and 90s, I tell you. And it has come in after 2000. Propusioplasty is again in the fashion because in the initial phase, there was always circumcision in all the cases of hypospadias. So around initial patients, around I can say around 30% of my patients, they require circumcision later on. So I modified my own technique and now I am on this technique. You can see the patients are also satisfied, surgeon is also satisfied.
One point I would like to add, Kishore sir here,
Yeah.
that trapezioplasty with a Snodgrass procedure should not always be a preference. Like it does have a worse result as compared to trapezioplasty with magpie procedure.
Yeah.
So one should be careful, like overzealous use of trapezioplasty should be avoided.
I don't prefer myself, but only on the demand of the
Patient.
patients.
Yeah.
Patients.
They always.
Thank you, sir.
Can you stop the screen share, sir, please?
Yeah, sure.
Right. Thank you, Prabhu. I hope it answered your questions. The next set is on post-op care by Dr. Chitti Babu. Chitti, are you there? So I think it was more on the type of dressing and the timing of catheter removal. Dr. Panjwani, would you like to take those?
Yeah, well, I tell you, we do only very simple dressing with the gauze pieces. We put a lot of betadine ointment over the stitch line, and we do the circular gauze dressings. My preference, how to do the change the dressing. I change the first dressing on the fourth day, second dressing on the usually eighth day, third dressing at the time of removal of the catheter. Okay. And regarding the removal of the catheter, I keep the catheter in case of the distal hypospadias for 10 days. Okay. And in cases of the proximal, I keep for the 12 days. Regarding the early anticholinergic, I routinely don't give the anticholinergic except in only those cases which got a bladder spasm because of the irritation of the tip of the catheter. So in those cases, I give the anticholinergic. Otherwise, I don't prefer to give the anticholinergic. Regarding the laxative, I give them the laxative routinely in the form of loose or other syrups and give them in a proper way so that they should not strain during the defecation. Otherwise, they will have a pericatheteric leak. Pericatheteric leak is not going to convert to your results, but it gives apprehension to the parents. Okay. Yeah.
Right, sir.
Regarding the catheter slip out, if the catheter is coming out after the 7-8 days, I don't try to put it again. I try once only after putting a lot of jelly. If it's not going easily, I don't push them. Okay. Unless until if they got a problem, then we go for the suprapubic. Otherwise, we don't do anything. If the catheter is blocked, there is the same policy. Catheter is blockage, we push them and open it, and otherwise there is no other special method.
Fine, sir.
Okay.
Yeah. Dr. Swati, would you take the next questions on follow-up?
Yes, ma'am. Hello?
Yeah, we can hear you.
Yeah. After the catheter removal, normally we'll follow around 10 to 14 days is the first follow. So how do you people follow up, ma'am?
Dr. Sarin?
Yeah, follow-up regimes also differ from person to person, but I think more or less is the same. She made a statement that all patients' catheter being removed 10, 14 days. I don't know. Did you say that?
No, she said followed up after 10 to 14 days of catheter removal, sir.
Okay. So first of all, how many days you keep the catheter? I mean,
Sir, actually it depends on the type of the hypospadias repaired. Normally for the distal hypospadias, 7 to 10 days will keep. And if it is a proximal hypospadias, then more than at least 14 days will keep.
Yeah, so that also differs. I mean, if you really go through the literature and my own experience, that also differs from person to person. My own department, everybody had a different protocol about when to remove the catheter. Yeah, people have done distal hypospadias without stents. People have done with splents. And people have kept the catheters up to 14 days. I mean, so all kind of things are there. But majority of the people would call these patients after everything is gone all right. The patient may have edema once the dressing and all is coming out, say 5th, 7th, 8th day, whatever. And then you let the patient go home with this catheter or splint, maybe if you're discharging as OPD procedure, as Dr. Panjwani was saying. And then call this, I mean, if you're sending them as OPD procedure, obviously first time you will call them when you have to remove the catheter 7th day, and then maybe after 2 weeks, and then maybe after 1 month or so. Now, to me, what is more important is how long to follow up, how frequently and how long to follow up. Again, there could be, there are people who are saying that keep following them, monthly, at least for 6 months, and then every few months up to a year, and then for many years. Sure. I think it's not like an appendectomy that you've done and gone. I mean, these patients should be under your follow for many, many years, because some of them will have secondary problems and some uroflow issues later. So these patients will be followed up for long. Role of elective calibration, Vikesh had already asked me a question, and I think we've already discussed it.
Yes, we've taken that.
Yes.
Is there any role of uroflowmetry? Mind it, yeah, literature started talking about uroflowmetry, but many of us do not have uroflowmetry in the first place. That is one. But if you have uroflowmetry, does that mean that every patient that you operate, you need to do a uroflowmetry? No, I don't think so. Only those patients who were symptomatic after your uroplasty, and you could do one uroflow for them. And if that uroflow is abnormal, but then you do an ultrasound and everything seems all right, then just keep them under follow-up and maybe repeat your uroflow after 1 year. I mean, it's no point doing uroflow every now and then. And I've kind of scanned the literature about uroflow also. There are people who used to do as a regimen, uroflow after 2 months and uroflow after 1 year of surgery. And they realized that at 2 months, they still feel that the tissues are pretty stiff and all that, and uroflows may not be normal. And they say that it's good to wait at least for 6 months to 1 year before you do your first uroflow. But it all depends. I mean, if the patient is quite symptomatic, comes within 2 months, then you probably would need to do a uroflow earlier than the recommended one at the age of 6 months. But how long? If the patient is doing very well, the steam is not a problem, no splaying, nothing is going far, everything is good, I don't think you will really bother to do uroflows in those patients.
Yeah, one quick point.
Sir,
Yeah,
yes,
I'm
sir,
talking,
actually,
again, I'm talking more in context of distal hypospadias. Yeah.
Swati, please, you were
sir,
saying something.
yes, sir. Actually, some literature says that the uroflowmetry we should do before the surgery and after the surgery. If the before the surgery, if it says good, then post surgery, if it says good, then no need of redo surgeries. But if before the surgery only, if it is a poor uroflowmetry, even after the surgery, it won't go good. So is
Okay,
it right? So
now let me tell you again, the statement that you made again is in context with the proximal hypospadias. Yeah? Why?
okay.
Preoperatively itself, these patients have a very high incidence of an associated urticle, and they may have poor uroflow to start with. Okay. And then there could be insults later by whatever urethroplasty may have done, and some stricture may have done, and again so it all depends. I mean, I personally, this is my personal bias, that for distal hypospadias, probably uroflows won't have too much of, unless you have done meatal stenosis, they will not probably have too much of problem.
Thank you,
Sir,
Professor Sari. Yeah, one
just
quick
last
point.
question.
Yeah, okay. Okay, you want to ask a question, Swati?
Yes, sir. Just
Yeah, please,
actually, you said elective calibration is no role. Is it right? I mean, if you want to do the elective calibration, we should do after the removal of the catheter or after 1 week. And if you want to do the calibration.
I personally don't do the calibration, and tell me, I've been actually for the last 23 years, but trust me, if I've done a urethroplasty, I will go along with the patient to the bathroom and see the urine myself. Okay. I think if I see a good urinary stream, that's as good as knowing that I could probably pass it 8 French, infant feeding tube down there. So one thing you must realize is that any kind of calibration is still an invasive procedure.
Right.
Yeah.
Painful also. Painful also.
Painful, scary for the baby. So it's mind it, abroad they do even MCUs in OT under sedation and GA. So all these calibrations and urethral catheterizations, they should be done if they are really required.
Okay, sir. I think this is enough for this particular section. One point which got missed is, like in Magpie, you can remove catheter a little bit early, like in 3 days. And there you can use a urethral stent, like a VP shunt tube or a feeding tube, which is cut partly.
VP shunt tube has been put for regular uretroplasties. Even
yes,
proximal hypospadias, people have used VP shunt. There are a lot of papers which talk about doing stentless surgeries for this distal hypospadias, but I have never dared it. I don't know if anyone of you have dared it ever.
So now we'll move on to the next set of questions. I think this is the last section.
Yeah, this is the last set. Tapasya, please go on.
Yeah. Okay. So, I know it's generally not, it doesn't happen, but do we really see a difference in the pubertal growth patterns in patients who've been operated for hypospadias? Is it, I mean, is there a significant difference between the proximal and the distal ones when they present at puberty?
Yeah, I tell you, I'm doing a study, long-term study on these type of cases. Okay. So in my view and what we are seeing at hospital, hospital has got a long experience of 40 years on hypospadias. So most of the cases, they got a normal benign growth pattern after the surgery, unless until they are operated multiple times. Okay. So if it are cases which are operated and corrected in a single time, they live like a normal male, other male people, and the growth pattern, penile growth pattern is the same. But those patients, when we got a multiple, even in the cases of penile hypospadias, in those cases, definitely the length is smaller than the normal penis. Okay. And Sudhir, another thing is, I will show you one slide, how we follow them in a long term. As you have seen another question, the long term, I'll show you one slide, how we are doing a study at our center. I'll show you just one slide and I'll take 2 minutes in those slides.
So while we move on to Dr. Panjwani's slide, I would like to say something about this particular session. This is one brilliant idea which Virender got it for SPU, and we were very skeptical like how it will go, because never someone has done something similar like this. There must have been like a lot of weaknesses here. So I request all of you, those who joined here, to give personal feedback to us so that we can improvise.
Vikesh, hello.
Yes, sir, we can hear you.
Can I finish
Yes,
this?
sir.
Yes, sir, please.
How does we are doing the long-term follow-up study in case of hypospadias? We put in 4 criteria. One is anatomy and cosmesis. Another is a voiding function. Third one is psychosexual adjustment and sexual function. Fourth one is a fertility. Okay. So regarding the anatomy and cosmesis, depend on the type of hypospadias, the technique, single stage, 2 stage, they require a redo surgery. Along with them, the basic things like glans shape, circumference of the glans, straightening and bending of the penis, buried, all these factors which I discussed. And if you really ask in the cases of the distal hypospadias, these patients, they live a normal life in all these 4 aspects. In case of anatomy, voiding function, psychosexual, unless until you have done some wrong technique with that patient. Like in the cases of you have developed the stenosis with after the tip repair, you got a spatuling of the wide urethra with the only flap. In those cases, you will have a difficulty and problems. And all these are patients of the distal hypospadias, psychosexually they are normal and their penile length is normal. Okay. And regarding the fertility also, they are got a normal. These are the pattern which we follow in case of a long-term study. You can see this slide, you got in your recording and you can follow them. Okay.
So just to add on, have you seen a change in the patient satisfaction as we've had improved suture materials, improved techniques? Has there been a change? Have you seen that?
I tell you, the longest follow-up in cases of hypospadias, my time is 27 years, I'm in a practice. But what I have seen in a super hospital, those patients which were operated in 1970, and those patients, most of them, they have got a coronal hypospadias even after the surgery, or they have got a glans, the deficient glans, different type of complication what we have seen in long term. Because the patients, they don't want to come again because of the shyness, because of the social problems. They don't come for the follow. If we call in the first study which I presented in the World Congress in 2016. That time we called 300 patients, only 96 data. Okay, so these type of problems are more common in the proximal hypospadias, but in case of the distal hypospadias, all of them, most of them, I can say 90%, their gland shape and everything is good. But what I realized in the last 15 years, the hypo results are far better than in the previous years because of the simplifying the techniques. In the past, when I started operating hypospadias from 1990. In those time of the patients, only we used to do only 2-3 techniques, and that depend on the surgeon's choice. Like I was working with the Professor Sopa, so many cases which we can do with the only we were operating with the Sopa technique, and magpie was very common, so the results were suboptimal. But nowadays, because of the multiple choices, as Dr. Sarina said, we got more than 250 techniques, and we can combine them so many techniques together. Like few patients at the table, they decide, they modify the technique with the tip procedure, they use the Matthew procedure also. So the results are far better than the previous.
Right, sir.
Dr. Sareen, you need to unmute yourself, please. Dr. Sareen, you're muted. Yeah.
I'm muting. My daughter had come and was making noise, so I had to mute.
Okay.
One thing which I wish to kind of say before we leave is that the so-called Snodgrass procedure, which was described in '84, was earlier described for the first time by one Dr. Reddy. Okay. And then one Dr. Rice also. Unfortunately, these two gentlemen did not get that kind of, it happens all the time. Even Penna's procedure was described by Stephen. So Snodgrass got the credit, but it was ready, and anybody who's interested, I can send that person the original article written by the Reddy and Rice much before Snodgrass ever even, went.
Dr. Sareen, if you want, I can send you the actual all technique which were published before these popular surgeons. Like Asopa also, it was with the Hudson. Like Breka procedure was with the different procedures. So even the Hadidi is using the other people's technique with his own name. So if you go before the 1950, all these techniques were there in the literature, but they were not popularized. So you can have a long discussion on this, but definitely they have popularized their technique. They were good marketing by them. Okay. So if you see Dr. Snodgrass' book, have you gone through Snodgrass' book on the hypospadias? He has condemned all other technique. Aditi is condemning. Vikesh knows this thing very well. We were together in the Russia and other places. He is condemning all other techniques. So every surgeon has got an era. Sopa and Duckett were having the era in 90s. Then came the Snodgrass and Breka. Nowadays are the Hadidis era. Okay. So, but I tell you, for the youngsters, you should assess so many cases and try to do the simple technique. Don't try to do the complicated cases technique in the distal hypospadias as well as in the proximal hypospadias. It's not that we should do fancy technique when we land up in the problem. This is my takeaway message.
Sure, sir. Can you stop sharing your screen, Panjwani sir?
Yeah, sure.
I think we had a nice discussion today, and now I hand it over to Virender to sum up and close the session and give a message about the next session which he is planning.
Sure, sir. I'm sure most of the questions that the students had were duly answered by our experts. So I wish to thank the students for being such enthusiastic participants in this discussion. If you have any more queries regarding this, you can always reconnect and we can pass it on to our moderators or try and answer ourselves. And thank you to both our moderators also, Dr. Sareen and Dr. Panjwani. Thank you so much. It's been quite some discussion. I had a brief announcement to make for our participants that all the 10 participants for today, we wish to tell you that you can go on to the website of SPU, that is www.SPU-IAPS.com. And if you are not a SPU member, if you register within the next 1 week, you get a 500 rupees waiver in your registration fees. That is valid only for the 10 of you for the next 1 week. So that is something we thought that we'll share with you for being such good sports today. So with that, I thank each one of you. Dr. Vikesh, any last words?
Yeah, I thank on behalf of SPU to everyone, and I think we need more inputs and suggestions to improvise this particular program, and we look forward for that.
Vikesh,
Yes, sir.
before we wind up, I'll tell you all the youngsters, tell them I got a one pen drive which got a
That's
35
brilliant.
procedures. You tell them you
I
have
was about to ask for it, sir.
yeah. So I got a one pen drive which has got a 35 procedures starting from supplementary procedures, fresh cases, distal and everything for the youngsters.
Okay.
Not for a big shots like Sareen and you.
Oh no, I'm a beginner. I've never called myself hypospadiologist. I remember Dasmeet using this word about 20 years back, and I had to really Google it. What is a hypospadiologist? I mean, I will never call myself a hypospadiologist. I do enough hypospadiology, but I'm not a hypospadiologist because I'm a complete pediatric surgeon. I have interest in onco, uro, and still I do everything from head to toe. So I'm a general pediatric surgeon who also does reasonable numbers of hypospadiology, but not too many of distal hypospadias. We do much more difficult proximal, scrotal, and those kind of hypospadias, which are supposed to be sent to the institutions. And I'm sure many of us in institutions have the same experience.
For us, for hypospadia, roti and rosy, we do so many cases, the distal one, even the
Sure, you could definitely be called a hypospadiologist.
I don't say myself a hypospadiologist because I know it's a vast subject, and every 2-3 years we got a different ideas, different things. Okay, and I'll ask one thing from all the youngsters: if you want some change in the pattern of teaching, you can tell us. You can tell the Virender. You are most welcome. Okay, if you want.
I'll connect with them. I'll take the inputs for sure. And the next session we are planning is on proximal hypospadias, and then the next one on complications.
Okay.
So, yeah. So with that, I thank each one of you, and we shall wrap up the session now. Thank you.
Thank you. Thank you.